Welcome to episode 6 of the second season of Clot Conversations from Thrombosis Canada. I'm David Airdrie, Executive Director. Today, Dr. Jamil Abdulrahman from University of Toronto and the University Health Network will be leading the interview as our co-host Maha Othman from Queen's University in Kingston is unavailable. It's great to be back. We're here to provide you with updates on diagnosis and management of thrombosis, featuring interviews with authors of recent research publications and highlights of education programs from Thrombosis Canada. Thank you for joining us for this episode.
In this episode, we'll be discussing a paper from the journal Circulation entitled The Efficacy and Safety of Andexanet Alpha in Patients with Acute Gastrointestinal Bleeding while taking Factor Xa inhibitors, an ANNEXA-4 Sub-analysis. We're pleased to have the lead author, Dr. Deborah Siegal, with us today. Dr. Siegal is from Ottawa.
Dr. Deborah Siegal is a clinician-scientist, hematologist, thrombosis medicine at the Ottawa Hospital, Associate Professor of Medicine and School of Epidemiology and Public Health at the University of Ottawa, and scientist at the Ottawa Hospital Research Institute. Her primary research interest is improving the safety of anticoagulant therapy, including optimizing the management of anticoagulant-related bleeding complications, restarting anticoagulants after bleeding, perioperative management of anticoagulants, and antithrombotic therapies for ischemic stroke in patients with cancer. Dr. Siegal is a member of the Board of Directors of Thrombosis Canada. Thanks for joining us for the first time and participating in our podcast today.
Thanks so much, David and Dr. Abdulrahman. It's wonderful to be here to talk about our study and our findings.
So I'm going to start off by asking, from your perspective, how big an issue is bleeding in DOACs and specifically GI bleeding?
So thanks for the opportunity to highlight bleeding complications, which limit the use of oral anticoagulants, even in 2024. And people are probably aware that anticoagulants are widely used all over the world to prevent and treat cardiovascular disease, which is still responsible for an estimated 18 million deaths annually. So older data suggests that the prescriptions of oral anticoagulants written in North America is more than 40 million a year, which is a lot of anticoagulant-related bleeding. And we see the increasing use of direct oral anticoagulants, or DOACs. And what's important to remember is that bleeding complications are the most important complication of oral anticoagulant use that limit this therapy and affects our decision-making. And of course, that affects about 2 to 4% of patients per year. And another 10 to 12% of people experience what we call clinically relevant non-major bleeding. So although we have access now to these DOACs, which reduce the risk of major bleeding and fatal bleeding, they do increase the risk of gastrointestinal bleeding as a class. And so it's important to remember that anticoagulants represent the drug class that have the most common adverse drug events, leading to visits to the emergency department, hospitalization, and even death. So even in 2024, we know that bleeding complications are important, lead to poor outcomes in our patients, and are very important to prevent and treat optimally. Of the bleeds, gastrointestinal bleeding represents the single most frequent site of bleeding. Up to 50% of major bleeds arise from the gastrointestinal tract.
Wow, didn't realize that. Can you tell us, what is Andexanet Alfa, and are reversal agents important in the time of DOACs?
Yes, thanks for that question. Of course, when somebody's having an anticoagulant-related bleeding, the anticoagulation interferes with hemostasis. And so particularly in patients who have major or severe or life-threatening bleeds, we want to be able to optimize their hemostatic status in order to stop bleeding quickly. And so we have seen the development of various reversal agents and strategies to help with hemostasis, including specific anticoagulant reversal agents like idarucizumab, which is used to reverse dabigatran, or Andexanet, which is used to reverse the effects of factor Xa inhibitors like apixaban and rivaroxaban and edoxaban, for example. And so the idea is, if we could reverse the anticoagulant effect of these drugs, we could optimize hemostasis for patients who are having severe life-threatening bleeds. Andexanet Alfa is a specific reversal agent targeted towards factor Xa inhibitor anticoagulants, and it acts as a decoy in order to take those drugs out of circulation in order to allow endogenous thrombin to be generated and endogenous hemostatic mechanisms to be optimized and to stop bleeding.
Great. Can you tell us about the ANNEXA-4 study?
The ANNEXA-4 study, which is the subject of the paper that we're discussing today, this was a single-arm prospective cohort study which evaluated Andexanet for the treatment of individuals who presented with major bleeding, and there are some specific definitions of that. Major bleeding on factor Xa inhibitors, and that included apixaban, rivaroxaban, edoxaban, or enoxaparin, which is also a type of factor Xa, inhibits factor Xa. And in this study, Andexanet was given to these individuals if they had a major bleeding or thought to have a major bleed. And the dose of Andexanet that was used was dependent upon the type of factor Xa inhibitor and the time that the patients or participants took their last dose. And so the Andexanet was administered as a sort of a short infusion, or it's so-called bolus, but really it was over 30 minutes, followed by a 2-hour infusion. And during the study, various measures of efficacy were evaluated, including the change in anti-10 activity, which is a measure of anticoagulant effect, and also hemostatic efficacy, which was determined using a combination of clinical, imaging, and laboratory criteria that corresponded to different bleed sites. So, for example, intracranial bleeding was adjudicated differently than gastrointestinal bleeding. And what's important to remember with the ANNEXA-4 trial is that there was a team or a panel of adjudicators who independently determined whether patients had severe enough bleeds to be entered into the analysis of efficacy, and also adjudicated the outcomes of thrombosis and rebleeding, et cetera, and hemostatic efficacy. So these patients were then followed for 30 days, and some of the outcomes, in addition to the ones I've already mentioned, included mortality, thrombotic events, and rebleeding.
Great. So you conducted a sub-analysis of the ANNEXA-4 study looking specifically at GI bleeds. Can you tell us about these patients who had GI bleeds?
Sure. So these are patients who had major GI bleeds, and the average age of the patients was around 76. So this is an older patient population. These are similar types of patients that we might see in our own clinical practices. 60% of people were male. As one might expect, atrial fibrillation was the most common indication for anticoagulation in the study, and just like it is in routine clinical practice. And about half of patients were receiving rivaroxaban, and half of them, 48%, and 39% were receiving apixaban. So it was predominated by rivaroxaban and apixaban treatments at baseline, with a few patients receiving those other treatments. On average, the time from the last dose of their drug to the onset of bleeding was 3.3 hours. So actually, they presented rather quickly with bleeding. And so there was a range of different bleed types available. The vast majority of the participants received things like red blood cell transfusions, and they also at baseline had some, indices of severity like hemodynamic, tachycardia or low blood pressure, hypotension in this cohort. We had endoscopy reports for some of the patients, and the most common site of bleeding was from the stomach, with peptic ulcer disease as the most frequent cause of bleeding.
Okay. And how did Andexanet alpha affect the lab markers of coagulation and clinical hemostasis in the sub-analysis?
So similar to the overall ANNEXA-4 study, after the administration of Andexanet, there was a rapid reduction in anti-factor Xa activity, again, which is the measure of anticoagulant effect, by over 90%. And that occurred pretty much right at the beginning of the bolus. And then there was that activity was remained low during the duration of the infusion, after which it was turned off. So again, in this study, what we were seeing similar to the overall ANNEXA-4 study was that Andexanet did what it needed to do, which was rapidly reverse the effect of these factor Xa inhibitor anticoagulants.
Right. And how about the risk of thrombosis and mortality? Could you comment on that?
So thanks. That's an important issue. Again, these patients are elderly and highly comorbid with cardiovascular disease. It's important to keep in mind that now they've presented with bleeding complications that are severe enough to warrant, admission to hospital, treatment with a reversal agent, and now their anticoagulants have been withdrawn. They are on that treatment for an underlying prothrombotic condition, and often they're again hospitalized for some period of time, potentially in the intensive care unit. Now, some patients, have undergone procedures or surgeries, for example, and so we almost anticipate that patients will be at risk of thrombotic events. which raises the important issue of resuming anticoagulants after the bleeding once it's safe to do that. So in this study, we did see that 7.3% of patients, or 8 patients, experienced a thromboembolic event during the 30 days of follow-up. And that's important to keep in mind, because we always want to make sure that we're resuming anticoagulants when it is safe to do so, to reduce the incidence of these events. There weren't any thrombotic events recorded after patients had started their oral anticoagulants again. I think one of the important points that you've identified here is that there really was a high rate of death among these individuals. 13 patients died within 30 days, and that's 12%. So here we have patients with gastrointestinal bleeds admitted to hospital, treated, and with an all-cause mortality rate of 12%, which to me suggests that these patients are at high risk. This is a high-risk event for patients, likely related to the bleed, but also related to patient characteristics, their age, their comorbidities, et cetera, which have now placed them at a high risk of death. So to me, these data suggest that bleed prevention is clearly important, because it's such a high risk time for patients when they do present with bleeding and are admitted to hospital.
So what are some of the challenges of assessing anticoagulant reversal agents in these type of single-arm cohort studies?
Yeah, this is a really important point, because it's hard to assess bleeding in general. And these are really difficult studies to do. And particularly for gastrointestinal bleeding, it's very challenging to be able to say when someone has stopped bleeding. For example, in a clinical trial, unless you have a camera down the lumen of the gastrointestinal tract, it's really hard to know. So, of course, there are specific criteria that were used for this study to evaluate hemostatic efficacy. And I should mention that those criteria were similar to ones that were developed for a reversal study of warfarin that was published in 2013 by Ravi Sirota and colleagues, PCC versus plasma for warfarin reversal. And so these definitions of hemostatic efficacy and how we measure that has sort of become standard, with similar criteria being proposed by the International Society on Thrombosis and Hemostasis. But admittedly, these definitions are based on things like hemoglobin and red blood cell transfusion, and really challenging to assess that. Further, I think to your point, here we have a single arm study where we don't really have a comparator group to understand the incremental benefits of this treatment, or incremental harms of this treatment compared to standard of care, placebo, et cetera. So that makes it a bit challenging. All we can say is, in this cohort of patients, which is a similar cohort to the patients we might treat in our clinical practices, these were the events that we saw, which I think is fairly representative and similar to other cohort studies that have been published in this space. And so certainly rates of hemostatic efficacy that we've seen here, and I can say that good to excellent hemostasis was reported in 82% of patients in the efficacy population, and thrombotic events occurred in 7.7% of patients. Those are similar results to what we've seen, across some other cohorts, plus or minus 10%, and it's difficult to compare across studies, right? So just to kind of be able to apply those studies indirectly and compare in the absence of a control group for any of those published studies, particularly with respect to GI bleeding.
So we recently have the ANNEXA-IRCT, which compared Andexanet Alfa to usual care in patients with anti-10A associated intracranial hemorrhage. Could you give us your thoughts on that study and the finding?
Yeah, and Andexanet was evaluated in a trial called ANNEXA-I, and this is the first and only randomized controlled trial of a reversal agent for the direct oral anticoagulants. And so in this trial, it was patients were included if they had intracranial hemorrhage, and they received either Andexanet or usual care, which could have included PCC. And the primary efficacy endpoint was effective hemostasis at 12 hours. And that meant some of the criteria as follows. So it's a hematoma volume expansion, which is a radiological measure of less than 35% at 12 hours, an NIHSS score increase of less than 7 at 12 hours. So that's sort of a more, clinical or functional measure. And then no rescue therapy administered between 3 and 12 hours. So that was the primary efficacy endpoint. Patients were followed for 30 days in this study, similar to ANNEXA-4. They also measured other things like the percent change from baseline in the anti-factor 10A activity, and other safety endpoints like thrombosis and 30-day mortality. They also finally measured MRS, which is a functional measure at 30 days, because that's, of course, an important measure in patients with intracranial hemorrhage or intracerebral hemorrhage because, of the significant functional impairments among survivors of that type of bleeding. And so it's important, again, in this trial, to remember that these results are limited to patients who had intracranial bleeding. And in fact, most of the patients had intracerebral hemorrhage, which is within the brain parenchyma. And what they showed was that patients who'd received Andexanet, a higher proportion of patients who'd received Andexanet experienced good or excellent hemostatic efficacy, and that was significant statistically significant compared to usual care. And the usual care arm, 86% of individuals were treated with PCC. What's also important to keep in mind for this study is that the rate of thrombotic events within 30 days. So among individuals who'd received Andexanet, there was an increase in the frequency of thrombotic events, particularly ischemic stroke, 6.5% of people in the Andexanet arm and 1.5% of people in the usual care arm. So that was also a significant difference. This trial was stopped early for benefit. So that means that, based on some interim analysis, the Data Safety and Monitoring Board recommended that the trial be stopped for benefit in terms of the hemostatic efficacy outcome, and which is also important to keep in mind. And then you can see, of course, as one might expect, mortality rates of about 26% overall, and no difference between the two groups in mortality, actually, or functional impairment at 30 days. But I should mention that, in this study, when we're looking at intracerebral hemorrhage, we know that the most important predictor of outcomes is final hematoma volume. And, even hematoma volume increases of 1 ml increase mortality. So the goal of achieving hemostatic efficacy and minimizing hematoma expansion in these patients is really important because it relates to functional outcomes. Unfortunately, in this study, we didn't see a difference in functional outcomes or mortality, but the challenge here is that the 30 days is really not long enough for us to assess that because, of course, patients have a hematoma in their brain and it takes months for that to resolve. And of course, it can take months then for any functional improvements to be seen. So the 30-day mortality, at 30 days, we would not expect to see differences in mortality or functional status. And it's just really difficult for us to know whether or not there could have been any differences or effect of reversal on those particular outcomes at 30 days. So that's a big challenge.
So today, 2024, where do you see the role of Andexanet compared to PCC for reversal of major bleeds on anti-10A DOACs?
Yeah, this is a good question. In Canada, Andexanet Alfa is approved. And so now hospitals across the country are looking to include it in their formularies. And certainly that's the case at our institution. I think the choice between Andexanet or other treatments like PCC really, needs to be individualized, based on how severe the bleeding is and the underlying thromboembolic risk. So we've seen that Andexanet, particularly in intracranial bleeding or intracerebral hemorrhage, improves hemostasis, less hematoma expansion, improved hemostatic efficacy, but at a cost of increased risk of thromboembolic events. There are some interesting sub-analyses that are emerging that are not yet published, but have been presented at conferences, which suggest that overall outcomes may be improved. For example, functional outcomes may be improved, by avoiding hematoma expansion compared to the increased risk of stroke, that those are not the functional implications of those types of events are different, and that the treatment with Andexanet favors, Andexanet was associated with, improvements in outcomes in those patients, and avoiding hematoma expansion versus increasing the risk of thrombotic events actually favors treatment with Andexanet for some patients. Now, I think the challenge here, we have one randomized trial, which is ANNEXA-I in intracerebral hemorrhage. We have a cohort study for other types of bleeding, which a large proportion of whom were treated for intracerebral hemorrhage. We had a small sub-study here of people with gastrointestinal bleeding, but they were the minority. And that's because the study was enriched for people with intracerebral hemorrhage at the discretion of the FDA for registration purposes. So I think we're really looking here at individualizing this. So you want to be able to give Andexanet to patients who are most likely to benefit And pending additional data in this space, it's important to keep in mind the thrombotic side of things. Some of the sub-analyses have also shown that there appeared to be an increase in the risk of thrombotic events in people who had a history of thrombosis, and so particularly arterial thrombotic events. And so what may emerge is a more individualized approach by saying, perhaps people with intracerebral bleeding, for example, who are presenting early with their bleed, who have a high rate of hematoma expansion already on their imaging, and who have no previous thrombotic events, may be the people who we prefer to use something like Andexanet. The challenge also is that the data for PCC, also contribute some uncertainty, as we've not really seen definitive data showing that PCC, reverses the effect of anticoagulants and improves outcomes again in a clinical trial, or even in a high quality prospective cohort study. So I think we're struggling now. What I suggest is that individualized case by case, protocolized approaches where we're ensuring that the people who are receiving this treatment, have severe bleeding, have a significant level of anticoagulant in their circulation, and therefore are most likely to benefit from this treatment. Should be the way that we approach the treatment of these patients, whether or not we're giving Andexanet or another treatment like PCC. But at the moment, we're still waiting for some more data to help us understand just who might be the right patient for different treatments.
Well, Dr. Siegal, you've covered a lot of ground today. Before we go, is there anything that we haven't discussed that you'd like to add?
No, I think I really appreciated the opportunity to talk a little bit about just the findings and implications of these treatments. And, there's a lot of discussions going on, and I encourage people to review and discuss at their own institutions. But I'd also like to make a plug that, reversal is only one part of management of these patients. Of course, it's important to, just recognize severe bleeding when it happens, and not just the bleed itself, right? Of course, we have gastrointestinal bleeding. We can recognize if people are hemodynamically unstable, but also think about the patient who's having the bleed. And whether or not, it's not just the bleed characteristics, but also the patient characteristics that contribute importantly to the outcomes. And we have some data coming out soon that will shed light on some of that. But also, I encourage people to, remember to resume anticoagulation if it's still indicated, when it's safe to do so. And if there's uncertainty about that, to have multidisciplinary discussions with other practitioners and with patients and families about it. And then finally, prevention is extremely important. So we want to prevent these bleeds from happening in the first place. And that's really where we need to focus our energy, by identifying and addressing risk factors, but also secondary prevention here. So making sure that people are monitored, know what to look out for, and when to seek medical attention when they're having bleeding problems.
Terrific. Thank you so much for taking your time today. And thank you to our audience for listening to Clot Conversations from Thrombosis Canada. We welcome your comments, questions, and suggestions on the podcast. And if you have any recommendations for future podcasts, please send them to us at info@thrombosiscanada.ca. Please subscribe to this podcast so that you're notified about the release of new episodes. And don't forget to check out our website, thrombosiscanada.ca, for education programs, clinical tools and guides like our bleed management order set, and including information on our annual education conference. Also, please consider donating to Thrombosis Canada to support our ongoing efforts to reduce morbidity and mortality due to thrombosis. Thank you both for your time today. It was great speaking with you.
Thank you.